All right, let's dive right into this. Welcome to part one of our explainer on revenue cycle management architecture and the absolutely critical mechanics of claim failures. Now, if you're a medical biller, a certified coder, or a denial analyst, you already know that the revenue cycle is just this incredibly complex machine. Well, today, we're going to establish the exact line where revenue leaks occur, and we're talking about the kind of leaks that cost practices thousands of dollars a single week. We're taking a really analytical, pragmatic look at why claims fail, where they fail, and the precise mechanical divergence between a rejection and a denial.
So here is our roadmap for today. We'll be walking through the complete RCM ecosystem, tracking error leakage, looking at the anatomy of rejections and the anatomy of denials, breaking down rejections versus denials, and then we'll wrap up with an intro to remittance architecture.
Starting off with Section 1, the complete RCM ecosystem, a macro view of the healthcare pipeline. Let's frame the entire financial life cycle before a claim ever hits a snag. Because to understand the failures, we first have to understand the perfect, frictionless path. Let's just track a claim sequentially. It starts right at the front end with patient registration, capturing demographics, verifying eligibility and benefits. Basically, this is where we make sure the patient actually has coverage in the first place. Then we move into the mid-cycle, dealing with referrals and authorizations, followed by the heavy lifting of medical coding and billing. That's where we translate clinical documentation into your CPT, ICD-10, and HCPCS codes. Next up is charge posting and claim submission over on the back end. And hey, if everything is perfect, we get to payment posting. But as we all know, perfection in this industry is pretty rare. By establishing this pipeline, we can see exactly where systemic friction naturally occurs.
Moving on to Section 2, Tracking Error Leakage. Vulnerabilities in the pipeline. Let's zoom in and see how this builds into specific failure nodes that bleed revenue. Not all leaks are created equal, right? As revenue professionals, we have to isolate the origin of the error. By separating these three distinct vulnerability zones, we can pinpoint exactly where our process is hemorrhaging capital. Think about it. Front-end access vulnerabilities usually boil down to simple human error, like a typo in a demographic field or someone forgetting to check active eligibility. Mid-cycle coding inaccuracies, on the other hand, are much more clinical. This is where we see a failure to follow NCCI edits, maybe incorrect modifier usage like slapping on a 25 or 59 modifier when you shouldn't, or global period billing violations. Finally, back-end billing leakage involves submission formatting errors and AR delays. Ultimately, you got to categorize the leak before you can ever hope to fix it.
All right, Section 3, Anatomy of Claim Rejections, the Clearinghouse Gateway. The crucial point here is understanding what actually happens when a claim hits its very first digital wall.
Now, this is absolutely vital to grasp. A rejection never, ever enters the payer's inner sanctum as an adjudicated record. It literally gets stopped at the gate, either by your EDI clearinghouse or the payer's very first line of defense. Why? Simply because it doesn't meet X12 standard electronic validation. Maybe it's missing a subscriber ID. Maybe the formatting is completely broken, or a required data field was just left blank. It's an unprocessed syntax failure. But, the good news here? Because it was never officially processed, you don't have to drag yourself through a lengthy, painful appeal. You can just correct the bad data and directly resubmit it as a clean claim.
Which brings us to Section 4, Anatomy of Claim Denials, the Adjudication Inner Sanctum. What happens when the formatting is flawless? It successfully sails through the clearinghouse gateway and actually gets into the payer's adjudication system. Well, here, we're dealing with a claim denial. The claim was fully processed, reviewed, and officially rejected based on complex clinical policies. Let's be clear, this isn't just a typo. The payer is actively stating that based on their coverage determinations or medical necessity guidelines, they are not going to pay for this service. And because it has been processed and officially entered into their system, you can't just fix a quick typo and hit resubmit. No way. This requires a formal appeal, reconsideration, or a corrective coding pathway backed up with real clinical documentation. Let's put them side by side in Section 5, Rejections versus Denials Breakdown, the core contrast. If you take away absolutely anything from this explainer today, let it be this mechanical divergence.
This 4-vector matrix is basically your foundational mental model for triaging defective claims efficiently. Let's walk through it. Vector 1, point of occurrence. Rejections happen pre-adjudication, while denials happen post-adjudication. Vector 2, root causes. Rejections are all about syntax, format, and missing data. Denials are about policy and clinical necessity. Vector 3, adjudication status. Rejections are completely unprocessed. Denials are processed and officially denied. And finally, Vector 4, resolution. Rejections mean data correction and direct resubmission. Denials mean you're diving deep into the medical records to draft appeals, correct unbundling issues, or provide that extra documentation.
Finally, Section 6, Intro to Remittance Architecture, or as I like to call it, the language of failures. Now that we know the mechanical difference of why claims fail, we have to preview the electronic language payers use to actually communicate those specific failures back to us via the 835 ERA. Think of this as a translation pipeline. When an 835 electronic remittance advice drops, it doesn't just broadly say no. It gives us a layered alphanumeric code structure, moving from the big picture financial impact all the way down to the hyper-specific clinical reason for the adjustment. First, it hands us a group code, then a reason code, and often an additional remark code to give us that extra bit of context. So before we can even think about arguing a denial, we have to look at the Claim Adjustment Group Code, or CAGC. This establishes exactly who is financially on the hook. CO stands for contractual obligation. This is a provider write-off, meaning you absolutely cannot bill a patient for this balance. Then there's PR, patient responsibility. That's going to be your copays, coinsurance, and deductibles. OA stands for other adjustments. This is basically used when no other specific group applies. And PI means payer-initiated reductions. These are adjustments the payer makes that usually shouldn't be billed to the patient. These 4 primary group codes define liability at the absolute highest level. Now, in our next explainer, we're going to dissect the specific reason codes, the CARCs, that attach to them, like CO97 for bundled services, or CO50 for lack of medical necessity.
Understanding the architecture of these failures is literally step 1 in protecting your revenue cycle. So I want you to ask yourself right now, is your team properly isolating rejections from denials, or are you wasting hours upon hours appealing claims that just needed a quick syntax fix? Until next time, keep analyzing those workflows and decode healthcare with Harshal.